So next we have Dr. Anaswara John. Yeah,
Nadhna.
which next page? Yeah. Leaving it. Dr. Nadhna Basheer on outcomes of FEMTO assisted CAIRS and simultaneous corneal collagen crossing. Okay, keratoconus.
Good afternoon, all. My study is on outcomes of FEMTO-assisted CAIRS and simultaneous corneal collagen cross-linking in keratoconus. Keratoconus is a bilateral, asymmetric, non-inflammatory progressive thinning of ectatic corneal disorder. Often due to the high irregular astigmatism, spectacles and contact lens corrections are dissatisfactory. Usually, collagen cross-linking is used for stabilizing the disease process. The purpose of our study is to evaluate the visual and topographical changes occurring following femto-second assisted corneal collagen, corneal allogenic intrastromal rings, CAIRS split with simultaneous cross-linking. It is a retrospective case series on patients diagnosed with keratoconus and underwent femto-assisted CAIRS. The study period is from September 2018 to March 2023. The inclusion criteria included patients diagnosed with keratoconus above the age of 18 years and with a best corrected visual acuity of 6/9 and below, and cylinder power of more than 2.5 diopters and pachymetry more than 400 microns. The exclusion criteria included central corneal scarring and visual acuity less than 1.2/60, not improving with the glasses. So the procedure is explained with a video. First, the stromal pocket is produced by the femtosecond laser. Then the donor cornea is removed of the epithelium and endothelium is stripped off. Using two different sizes of corneal punch, femtosecond CAIRS segment is created and it is fashioned according to the arc length required. Trimming of the edges is done and it is inserted into the stromal pocket, which is already created using a pigtail stromal dissector. This video shows a double CAIRS segment, asymmetric double CAIRS segment. After this, epithelial debridement is done and cross-linking is done in the same setting. 22 eyes of 20 patients with keratoconus were included in the study. The mean age group was 25.9, plus or minus 7.8. 10 eyes were females and 12 were males. Mean follow-up period was for 10 months. The visual changes measured were the uncorrected visual acuity, which improved from 1.06 plus or minus 0.2 to 0.75 plus or minus 0.2, and best corrected visual acuity improved from 0.9 plus or minus 0.2 to 0.3 plus or minus 0.5. The spherical mean sphere improvement from 3.2 plus or minus 4.8 to 0.5 plus or minus 1.23. Refractive cylinder power is also increased improved from 4.35 to 2.4. This mean spherical equivalent showed improvement from 5.15 to 1.79, and all the p-values were statistically significant. Then coming to the topographical changes, we measured K1, K2 and Kmax. It showed improvement in all, and p-value was shown statistically significant. The only complications we have found was mild stromal inflammation in 5 eyes, which was well controlled with a topical steroid application. This is a patient which came to us with preoperative vision of 660, which was improving with minus 6 cylinder, improving to 618. This is the topography where you can see the steep point is around 58.2. After CAIRS, the 1 month after CAIRS, the postoperative vision acuity improved to 624. With minus 1.5 D cylinder, it improved to 612. So you can see the steep area is well flattened. That is around 58. It reduced to 47. You can see the flattening here. Around 11 diopters, it has flattened. This is the clinical photograph of the CAIRS segment, and this is the ASOCT, where you can see the implant is placed 230 microns from of depth, and the total thickness of the CAIRS used was around 580. This is another patient who came with asymmetric bow tie with inferior steepening. So this is pre-op Pre-op, the visual acuity was 5/60, improving to 618 with 3.5 diopter cylinder. Here, the mean, the steep point is around 59.3. This is post-operative, where you can see it's well flattened, and the steep point is around 45.4. The visual acuity improved from 5/60 to 636, improving to 69 with 3 diopter cylinder. So this is the clinical photograph of the same patient, and you can see the ASOCT segment image where the KS is implanted at 200 microns depth. So coming to the discussion, cross-linking is used for stabilization of progressive keratoconus. In a study conducted by Hendricks et al., they found that overall progression is around 2.2, which is very good, and progressive extreme flattening is occurring in some of the cases. That is around 7 patients develop progressive flattening, which has caused a loss of best-corrected visual acuity. Among that, one eye had a flattening of around 11 diopters, which needed a corneal transplantation. Now, the complications of cross-linkings are very minimal, but the most common is the post-operative stromal haze and the progressive flattening, and rarely now we are finding corneal melts and thinning associated with this procedure. So in this setting, it is better to give an additive procedure like an intact or a KS to support the host cornea. KS have better biointegration and lesser complication rates like extrusion, migration, and neovascularization. Similar study done by Jacob et al., where they included 24 eyes of keratoconus, KS with cross-linking. So there they have found that stromal depth is around 314. Their average improvement was 2.79 lines in uncorrected and 1.29 lines in the best-corrected visual acuity. Study conducted by Jafari Nasab et al. And Hadi et al., they also found that the refractive error was getting improved with the stromal implants. Here, in the study, they didn't combine cross-linking together. The two additional points which they told is that displacement of the C point towards the corneal center, which improved the visual quality, as well as the improvement in the third and fourth order aberration due to reduction in myopia. Limitation of our study was that we didn't include the higher order aberration. So conclude, KS with CXL is a newer modality of treatment for improving the visual quality as well as topography of patients with keratoconus. They can either eliminate or delay the need for keratoplasty. Further, long-term studies are required to plan KS as a standard